Hey everyone, welcome to this explainer on burn management. Today we're taking some seriously dense, heavily tested surgical theory and translating it into high-yield visual concepts. Here's an incredibly crucial point right out of the gate. When you are calculating total body surface area, or TBSA, you must never, ever count superficial first-degree burns. Only your partial thickness, which are the second degree, and full thickness third-degree burns actually count toward your fluid resuscitation calculations. This is such a classic trap. Just lock it in your brain right now. Superficial burns don't cause significant capillary leak, so they literally do not count for the math. Now, when comparing our two primary calculation tools, there's a big distinction. For adults, we rely on the rapid rule of nines. That's 9% for the head in each arm, 18% for the anterior trunk, posterior trunk, and each leg, plus that 1% for the perineum. But if you're dealing with pediatrics, the Lund-Browder chart is absolutely essential. Why? Well, because it accounts for their totally different body proportions. Kids have proportionally way larger heads and much smaller legs than adults. So if you try using the rule of nines on a toddler, you're going to get an inaccurate and honestly a potentially dangerous calculation.
But what if you've got small, scattered burns that just don't neatly fit into those major body zones? That's where you use the rule of palm. The patient's own palm, and importantly, this includes their fingers, equals exactly 1% of their TBSA. And remember, it is the patient's palm, definitely not yours.
Moving right along to Section 2, Burn Depth Classification.
When you look at the clinical picture of burn depths, the differences are striking. Notice how superficial partial burns, your classic second-degree burns, present with blisters and are incredibly painful. That's because those nerve endings are exposed but still viable, and they'll usually heal up in about 1 to 3 weeks. But then, look at the full-thickness, third-degree burns. They appear white, leathery, or charred, and counterintuitively, they are completely painless. No pain at all, because the nerve endings are entirely destroyed. Also, pay attention to deep partial burns. They're mottled, much drier, and take well over 3 weeks to heal, which puts them at a super high risk for scarring and means they're probably going to need grafting.
Which brings us to Section 3, the Parkland formula and fluid resuscitation.
Okay, you absolutely must memorize this formula to calculate the total fluid required for that critical first 24 hours of resuscitation. It's 4 ml multiplied by the patient's body weight in kilograms multiplied by the percent TBSA. That right there is your gold standard starting point. But just knowing the total volume, that's really only half the battle. Timing is literally everything. Remember the golden rule. Time is tissue. You have to administer the first 50% of those calculated fluids within exactly 8 hours from the actual time of injury, not the time they rolled into the hospital, the time they were injured. The remaining 50% is then given over the next 16 hours. So, if a patient arrives late to you, you've got to give rapid catch-up fluids to complete that first half before that 8-hour window from the injury time slams shut.
When it comes to picking your fluid, Ringer's lactate is always your go-to. It's the preferred crystalloid because it closely mimics normal plasma electrolyte composition. But please keep in mind, your calculation is just a baseline. You have to meticulously titrate these fluids based on how the patient is actually responding clinically, keeping a super close eye on markers like lactate and base deficit.
And speaking of clinical response, the absolute best indicator that your fluid resuscitation is adequate is urine output. Urine output is king here. Notice that the targets are strictly different for adults and children. For your adult patients, you're aiming for 0.5 to 1 milliliter per kilogram per hour. For the kids, you need to hit a stricter target of exactly 1 milliliter per kilogram per hour. That is exactly how you know if your Parkland calculation is actually doing its job.
All right, time to put you in the hot seat. Section 4, Rapid Fire Exam MCQs.
I'm going to fire off 5 critical calculation and timing questions, so lock in your answers mentally before I reveal them. Ready? Number 1. A 70-kilogram adult with a 30% TBSA burn. What's their 24-hour fluid requirement? Number 2. What's the TBSA for an entire right upper limb? Number 3. Anterior trunk percentage. Number 4. What is the exact time frame for the first half of fluids? And number 5. If a patient arrives 3 hours late, how much time do you have left to give that first half of the fluid?
Okay, let's see how you did. For number 1, the answer is a massive 8,400 milliliters. You get that by multiplying 4 by 70 by 30. For number 2, the right upper limb is 9%. Number 3, the anterior trunk is 18%. For number 4, the first half of fluid is given in the first 8 hours from the injury. And definitely look at number 5. If a patient arrives 3 hours late, you only have 5 hours left to push that massive first half fluid bolus. You really have to work fast.
Let's keep the momentum going with Group 2. Number 6. What's the most accurate method for kids? Number 7. What percentage is the palm? Number 8. Which burns are actually included in the TBSA? Number 9. Who is the rule of nines least accurate in? Number 10. What's the total for an anterior trunk plus the entire left arm? And number 11. What's the perineum percentage?
All right, here are your answers. Number 6. The Lund-Browder chart is best for kids. Number 7. The palm, fingers included, is 1%. Did you catch the trap in number 8? Superficial burns never count toward your TBSA fluid calculations. It's only partial and full thickness. Number 9, the rule of nines is least accurate in children. Number 10, the anterior trunk and left arm equal 27%. That's just 18 plus 9. And number 11, the perineum is exactly 1%.
Okay, final rapid-fire round. Let's go. Number 12, what depth is blistered? Number 13, which one is leathery? Number 14, what's the deep partial healing time? Number 15, which burn hurts the most? Number 16, what is our preferred fluid? Number 17, what's the adult urine target? Number 18, why is full thickness painless? Number 19, what is the true nature of the Parkland formula? And finally, number 20, what do you call a red, dry burn that heals in a week?
Awesome. Let's break these down. A blistered burn is superficial, partial. Leathery is full thickness. For number 14, deep partial burns take over 3 weeks to heal and often need grafting to stop hypertrophic scarring. The most painful is superficial partial. We always prefer Ringer's lactate. Adult urine output targets are 0.5 to 1 ml per kilogram per hour. Full thickness is painless purely because of nerve destruction. Number 19, remember, the Parkland formula is just a guide. And that simple red burn, that's just superficial, or a first-degree burn.
You made it. Section 5, High-Yield Clinical Pearls Summary.
Let's cool down and really lock in these major takeaways. Use Lund-Browder for the kids and nines for the adults. Never, ever calculate first-degree burns into your fluid math. You need to rapidly execute that Parkland formula at 4 mLs using Ringer's lactate, and you got to push half that volume within 8 hours of the injury time. But at the end of the day, urine output is king. It's the only way to know if your math matches reality. And visually, blisters always mean partial thickness, while a leathery, painless burn means full thickness.
Section 1. Diagnosing inhalation injuries, also known as the silent killers. Listen, when a burn patient comes in, your index of suspicion needs to be sky high. If you're seeing facial burns, singed nasal hairs, a hoarse voice, or soot in their mouth, you've got to act fast. But remember, a diagnosis isn't just about your clinical gut feeling, right? Fiber optic bronchoscopy is the absolute gold standard here. It lets you get right in there to directly visualize any airway edema, charring, or soot. And while you're doing that, you absolutely must draw blood to check those carboxyhemoglobin levels, which actually leads us right into our first major toxic exposure. Moving on to Section 2, carbon monoxide poisoning, or what I like to call the oxygen thief. To put this physiological danger into perspective, carbon monoxide binds to hemoglobin 200 times more strongly than oxygen. 200 times! It literally hijacks the hemoglobin, forming carboxyhemoglobin, which completely wrecks cellular respiration and starves the tissues of oxygen. Now, textbooks always talk about that classic cherry red skin, but in the real world, keep your eyes peeled for much more common subtle signs like headaches, dizziness, severe nausea, and confusion. And here's where you, as the clinician, can massively change a patient's trajectory. On standard room air, it takes a sluggish 4 hours for the carboxyhemoglobin half-life to drop. But if we crank that up and administer 100% oxygen through a non-rebreather mask right out of the gate, we slash that half-life down to just 1 single hour. That's why 100% oxygen is your absolute non-negotiable first line of defense. Okay, Section 3, the cyanide toxicity profile. This is our synthetic threat. You definitely want to pay attention to this comparison for your exams. Notice how carbon monoxide and cyanide actually kill you in totally different ways. While CO blocks oxygen transport in the blood, cyanide goes straight for cytochrome oxidase. It completely shuts down cellular respiration at the tissue level, which leads directly to severe lactic acidosis. For treatment, hydroxycobalamin is your superstar. Why? Because it directly binds to the cyanide to form non-toxic cyanocobalamin. Sure, sodium thiosulfate and sodium nitrite are on the table as alternatives, but hydroxycobalamin is absolutely your top-tier exam answer. Let's dive into Section 4, airway management protocols. Honestly, this is arguably the single most time-sensitive part of burn trauma care. If you have a major burn with suspected inhalation injury, step one is always, and I mean always, a rapid airway assessment and slapping on that 100% oxygen. Step two is early intubation, and here is a crucial detail. You use an uncut endotracheal tube. You do this to account for the massive facial and airway swelling that is inevitably coming. You do not want that tube slipping out when the edema hits. Finally, manage them on a long protective mechanical ventilation strategy and be super careful to avoid fluid overload because that will just make pulmonary edema so much worse.
And speaking of swelling, timing is everything. Airway edema doesn't just hit its peak the second they roll through the ER doors. It actually reaches its maximum peak between 24 and 48 hours post-injury. This delayed peak is exactly why we intubate early, the moment we see signs of stridor, hoarseness, or neck burns. If you sit around waiting for that edema to max out, it's too late. You will lose the airway.
All right, Section 5, Burn Center Referral Criteria. Knowing exactly when to triage a patient to specialized care. You've got to memorize these total body surface area, or TBSA, thresholds based on the American Burn Association. You refer adults with partial or full thickness burns over 20% TBSA, and for children, it's over 10%. Now, if we're talking full thickness burns, that threshold drops all the way down to just 5%. And watch out for this classic exam trap. Superficial burns under 10% TBSA do not strictly require a burn center referral. Don't let them trick you with that one.
But remember, it's not just a numbers game. Just having an inhalation injury automatically meets the major criteria for a burn center referral, regardless of the burn size. The same rule applies for burns to high function or cosmetic areas. Think the face, hands, feet, genitalia, or any major joints. Throw in electrical burns, chemical burns, or any concomitant major trauma, and they immediately require that specialized transfer.
Section 6, High-Yield Rapid-Fire MCQs. We built the foundation, so let's put it to the test. Okay, imagine you're standing right there in the trauma bay. A patient rolls in, you hear hoarseness, you see soot in the oropharynx, the classic early clinical signs of upper airway involvement. What is your immediate next step? The answer? Definitive, early endotracheal intubation. Period. Hoarseness and stridor are screaming at you that a lethal airway obstruction is coming. You don't wait for imaging, you don't wait and see how they do, you secure that airway right then and there. Next up, carbon monoxide pathology. We know it binds aggressively, but what is the exact mechanism of action here, and at what specific carboxyhemoglobin level do you actually consider pulling the trigger on hyperbaric oxygen? So CO basically launches a two-pronged attack. It causes direct cellular toxicity, and it forcefully shifts the oxyhemoglobin dissociation curve to the left. That means whatever little oxygen is actually bound to the hemoglobin refuses to let go and feed your starving tissues. You need to consider hyperbaric oxygen once those carboxyhemoglobin levels cross the 25% mark, or if you're seeing severe neurologic symptoms like seizures, coma, or if the patient is pregnant. All right, next question. Thinking back to those burning plastics and synthetics, why is hydroxycobalamin the absolute preferred antidote for cyanide poisoning? Well, yes, it beautifully binds cyanide to form non-toxic cyanocobalamin. But its real clinical superpower? It's incredibly safe. You can administer it empirically right there in the field or the ED before you even have lab confirmation of cyanide toxicity. When minutes matter, that safety profile is a total game changer. Let's finish up by combining two high-stakes scenarios. What is the most common cause of early death in inhalation injury? And what is your top priority in an electrical burn combined with an inhalation injury? The answer to both is fundamentally the same: airway obstruction and hypoxia. They are the top killers early on. Because of that, securing the airway is your undisputed, absolute first priority, no matter what kind of burn you're dealing with.
1. Emergency procedures, relieving the pressure. When a severe burn patient rolls through those doors, relieving pressure and restoring circulation are your absolute immediate priorities.
Okay, let's look at the heavily tested distinction between these two otomies. An escharotomy is an incision that cuts only through the rigid eschar. That's the full-thickness burn tissue. And you can usually just do this right at the bedside with electrocautery or a scalpel. But a fasciotomy, that is a much deeper incision that goes completely through the fascia to release those muscle compartments. That one requires a trip to the OR and definitely carries a higher risk of bleeding and infection.
So when do we actually do an escherotomy? Well, looking at these indications, it's absolutely critical to remember that circumferential full-thickness burns of a limb that cause absent distal pulses, a cool limb, or delayed cap refill demand this procedure.
It's also your go-to for circumferential chest burns that are causing restrictive respiratory compromise. But catch this, you do not do this for superficial partial thickness burns. Now contrast all of that with deep electrical burns causing massive muscle swelling inside the arm or leg. That's compartment syndrome, and that demands the much deeper fasciotomy.
Section 2. Initial wound management, from clean to clear. Once your patient is hemodynamically stable and those immediate pressure threats are handled, we move on to the foundational principles of burn wound care.
For initial care, you always start with your ABCs and fluid resuscitation. Then, you clean the wound out with normal saline. Notice step 3 right there? Large, tense blisters must be debrided. This is a huge exam point. We do this to prevent infection and so we can actually get a proper assessment of the wound bed. Small blisters, though, you can just leave those intact. And finally, we apply our topical antimicrobials.
Now, this breakdown of topical agents is virtually guaranteed to show up on your exams. Definitely commit it to memory. Silver sulfadiazine, or Silvadene, is your broad-spectrum, painless first-line agent. Then you've got mafenite acetate, which is heavily tested because it has amazing penetration into cartilage. That makes it the absolute go-to for deep ear burns, but the big drawback is that it's really painful. Silver nitrate is fantastic for gram-negative coverage, but watch out because it can cause major electrolyte imbalances. And finally, bacitracin, or petroleum gauze, is preferred for facial or superficial burns just to prevent desiccation.
So the most crucial point for stable patients with deep partial or full-thickness burns is early tangential excision. You really want this to happen within 3 to 5 days. Why does that matter? Because getting rid of that dead tissue early significantly reduces the risk of infection, minimizes scarring, and it drastically shortens how long that patient is sitting in a hospital bed.
Section 3. Skin grafts and healing. Rebuilding the barrier. All right, let's head to the operating room and see exactly how we permanently close these excised wounds. Say you have a patient with a massive total body surface area burn. We simply might not have enough healthy donor skin to cover it. That's where meshed grafts come in. By running the skin through a mesher at ratios like 1.5 to 1 or 3 to 1, we vastly expand the area our donor skin can cover. It stretches out like a net. Plus, those little mesh holes allow underlying fluid to drain out, which, as we'll see in a second, is completely vital for graft survival.
Let's compare our two main types of grafts. The split-thickness skin graft, or STSG, takes the epidermis and just a part of the dermis. This is your absolute workhorse for major burns, because the massive advantage here is that the donor site heals spontaneously on its own. On the other hand, the full-thickness skin graft, or FTSG, takes the entire dermis. Now, while it has a much smaller pool of available donor sites, it gives you way better cosmesis and functional outcomes. So you're going to prefer this for highly visible or functional areas. Think the face, the hands, and the eyelids.
The timeline of how a graft actually takes is honestly an incredible biological process. For the first 48 hours, the graft survives by something called imbibition. It's essentially acting like a giant sponge, soaking up nutrients directly from the wound bed. Around days 3 to 5, we enter in osculation, which is where the capillary networks actually begin to align and hook up. Finally, after day 5, true revascularization happens, and you get permanent blood flow.
Unfortunately, grafts don't always take. If you look at the causes of graft failure, hematoma and seroma are the absolute most common culprits. Why is that? Well, a collection of blood or fluid physically lifts the graft right off of the wound bed. If it's lifted up, that delicate imbibition and an osculation process we just talked about can happen. Other causes include infection, shear forces, like if the patient moves too much, and a poor vascular bed, like trying to graft over bare bone or tendon.
To protect against those exact failure risks, post-graft care demands a really aggressive strategy. Immobilization of the grafted area is critical to prevent shear. We also rely heavily on negative pressure wound therapy. You probably know them as wound vacs, or bolster dressings. These are a real game changer because they actively reduce those shear forces and suck away excess fluid, which directly fights against our #1 enemy, hematomas and seromas.
Section 4. Rapid Fire Exam Pearls. Test your knowledge. All right, it is time to pressure test everything we just learned. Let's do a rapid-fire review of the most commonly asked clinical scenarios. Try to answer in your head before I give it away.
First question. Think back to the infection risks we discussed. What specific bug just absolutely loves burn wounds and destroys grafts?
The answer is Pseudomonas aeruginosa. This is a classic exam detail, folks. It's a gram-negative bacterium that thrives in these environments, and you absolutely cannot forget it.
Next up, let's test your knowledge on graft healing mechanics and those vulnerability windows we mapped out earlier.
Because a split-thickness skin graft leaves part of the deeper dermis behind, the donor site actually heals by reepithelialization from the remaining dermal appendage. And as for shear force, you must aggressively immobilize that patient during the first 5 days. That's right when imbibition and osculation are happening, and any shear at all will disrupt those fragile connections.
Okay, applying what we learned in Section 1 about emergency pressure release. A patient's chest literally cannot expand to breathe. What's the exact name of the intervention here?
You perform a bedside chest escharotomy. This perfectly relieves that rigid, tight restriction caused by the burned tissue, letting the chest wall expand normally without unnecessarily cutting deeper into the fascial plane.
Let's revisit the graft failure stats. It's so important it deserves to be asked again. What was the towering #1 cause of graft failure?
Hematoma or seroma formation takes the top spot. Once again, it physically acts as a barrier, preventing graft adherence and totally stopping the revascularization timeline in its tracks.
To leave you fully prepared, take a screenshot right here of these 5 absolute gold standard pearls. An eschorotomy goes through eschar, while a fasciotomy goes through fascia. Silver sulfadiazine is your first-line topical. STSGs are for large burns, FTSGs are for the face and hands. Hematomas ruin grafts. An early excision within 3 to 5 days is the standard of care.
With all this in mind, Section 1, the timeline of burn complications. So timing is absolutely everything here. There's this very clear chronological divide when it comes to burn complications. And knowing what threatens a patient in week 1 versus week 2, well, that totally dictates your management strategy. In that early phase, so less than 1 week, we're battling the immediate, acute aftermath. We are on high alert for hypovolemic shock, acute kidney injury, pulmonary edema, Curling's ulcer, and inhalation injuries. But once we cross that 1-week mark, the whole landscape shifts. The late complications set in. The big one, infection and sepsis. That's actually the leading cause of death after week 1. We're also looking at hypertrophic scars, contractures, ARDS, multi-organ dysfunction, psychological impacts like PTSD, and even heterotopic ossification.
Now you might be wondering, what exactly is Curling's ulcer? It's a classic early systemic response. Basically, it's an acute gastric or duodenal ulcer. But why does the stomach care about a burn on the arm or leg? Well, the body is under such massive stress that it literally shunts blood away from the gut just to deal with the severe trauma everywhere else. This causes severe mucosal ischemia. Because we know this happens so predictably, hitting these patients early with proton pump inhibitors, PPIs, or H2 blockers is standard, non-negotiable prophylaxis.
Moving right along to Section 2, hypermetabolism and nutritional support.
To really put this into perspective, your normal resting energy expenditure is, your baseline 100%. But a severe burn patient, their hypermetabolism skyrockets up to 200, even 300%. It's wild. It is literally as if their bodies are running a marathon 24/7 just to heal those massive wounds and fight off systemic inflammation. They are basically an absolute overdrive.
And because of that extreme hypercatabolic state, you really need to memorize this exact number, 1.5 to 2 grams per kilogram per day. That is the absolute mandatory high-protein dietary requirement. These patients are losing massive amounts of protein straight through their open wounds and through hypercatabolism. Hitting this high-protein goal isn't just a suggestion. It's absolutely crucial for their recovery.
So how do we actually deliver all that nutrition? The gold standard is early enteral nutrition. That means feeding them through the gut within the first 6 to 12 hours. Why is this such a big deal? By feeding the gut early, you keep the gut barrier intact. That stops bacteria from leaking out of the gut and into the bloodstream, a process called bacterial translocation. Preventing that drastically cuts down the risk of a fatal systemic infection. To figure out the specific calories they need, clinicians use the Carreri formula or the Toronto formula. And hey, don't forget the micronutrients. You're going to need vitamin C for collagen synthesis, plus vitamin A and zinc to really drive that overall wound healing process.
All right, let's dive into Section 3, burn infection and sepsis. Okay, like we talked about, after week 1, infection is the primary enemy. Pseudomonas aeruginosa is by far the most common bug we see. It absolutely loves moist burn wounds. Its classic clinical signature? A greenish exudate that has a really distinct, foul, almost fruity smell. Oh, and it's also the #1 cause of graft failure, so watch out for that. You also have to keep an eye out for MRSA, Acinetobacter, and Klebsiella. Now, if you happen to see black, necrotic tissue forming, that is a huge red flag for a fungal infection, like Mucor or Aspergillus.
Regardless of the specific bug, the general signs of infection you have to catch are a partial thickness wound converting into a full thickness wound, a sudden spike in fever, a high white blood cell count with a left shift, and any worsening in the patient's mental status.
But here is the real diagnostic dilemma that makes this so challenging. Diagnosing sepsis in a burn patient is incredibly difficult. Why? Well, because the patient's normal baseline response to a severe burn completely mimics sepsis. Even without an infection, they are already tachycardic, they already have a fever, and they're heavily inflamed from that hypermetabolic state. So the normal diagnostic criteria are pretty much useless here. Clinicians actually have to use modified guidelines, specifically the American Burn Association's sepsis criteria, just to spot the real sepsis through all that loud physiological noise.
So how do we stop this from happening? The definitive sequence to prevent burn infections really comes down to 3 steps. Step 1, and I literally cannot emphasize this enough, is early excision and grafting. It is hands down the absolute most effective way to reduce infection. You go in, surgically remove the dead tissue, and get a graft on it right away. That's followed by Step 2, which is maintaining strict asepsis, and Step 3, the diligent application of topical antimicrobials.
Okay, let's switch gears. Section 4, Rapid Fire Exam MCQs. Time to put your attending physician hat on.
Let's see what's stuck from our infection review. Question 1. What is the most common cause of death after week 1? That's sepsis and infection. Questions 2 and 12. Most common bug, classic green pus, fruity smell? Pseudomonas aeruginosa. Question 7. What's a major clinical sign of a burn wound infection? Conversion of a partial to a full thickness wound. Question 10. Most common cause of graft failure? Again, Pseudomonas. Question 16. The single most effective way to reduce infection? Early excision and grafting. And question 19, black necrotic tissue strongly suggests what? A fungal infection, like mucor or aspergillus.
Keeping that momentum going, let's hit nutrition. Question 4, preferred route and timing of nutrition, early enteral, within 6 to 12 hours. Question 5, what's that precise protein requirement? 1.5 to 2 grams per kilo per day. Question 9, what exactly does early enteral feeding reduce? Bacterial translocation and sepsis. Question 11. The hypermetabolic state increases resting energy expenditure by how much? A whopping 200 to 300%. Questions 14 and 17. Zinc helps with what? Wound healing. And the vitamin for collagen synthesis? Vitamin C. Finally, question 20. How do we calculate calories? The Carreri or Toronto formula.
Last round, let's hit complications. Question 3. What exactly is a Curling's ulcer? A stress-induced gastric or duodenal ulcer. Question 8. Standard prophylaxis for it? PPIs. Question 6. Hypertrophic scarring is most common in which type of burns? Deep, partial, thickness burns. Question 13. What's the late complication that causes joint deformity? Contractures. Question 15. Why is burn sepsis so incredibly hard to diagnose? Because of the patient's baseline hypermetabolism and inflammatory response. And lastly, question 18. Heterotopic ossification is a known complication, especially around which joint? The elbow. Honestly, if you nailed those answers, you are going to absolutely crush this topic on the wards.
Finally, Section 5, high-yield burn pearls.
Look, if you've zoned out at any point, tune back in right now. If you only remember one slide from this entire explainer for your upcoming exam, let it be this one. Lock these 5 points in your memory. 1. Sepsis is the #1 late cause of death. 2. Pseudomonas is your most common bug, thriving in those moist wounds. 3. Early enteral nutrition is the absolute gold standard to protect the gut. 4. Curling's ulcer is a major risk that demands PPI prophylaxis. And 5. Early excision and grafting is, hands down, your very best method for preventing infection. Burn these into your brain.
Airway and initial resuscitation. Let's dive right into the absolute most critical first steps when a major burn patient rolls through your doors. These overarching priorities right here directly answer some of the absolute most frequently tested clinical questions. If you're ever asked for the #1 absolute first priority in managing a major burn patient, it's always airway assessment and management. And once that airway is locked down, you move straightly through breathing and circulation, straight to IV access and fluid resuscitation. Only after all that is sorted do you even think about wound care. Now, what's really crucial to grasp here is why airway management takes absolute precedence. It's because airway edema can blow up incredibly fast. You literally cannot wait for a patient to stop breathing. You've got to be proactive and look for indications for early intubation. We're talking clinical signs like stridor, hoarseness, or respiratory distress.
You also need to act immediately if you see facial or neck burns, singed hairs, or carbonaceous sputum, because those strongly point to an inhalation injury. Plus, circumferential neck burns, those demand priority airway protection, as does a massive burn of over 40% TBSA or, any altered level of consciousness.
All right, let's test this with a highly specific, very frequently tested clinical scenario. When you do intubate, why is an uncut endotracheal tube preferred in burn patients? The key point here is that it allows for facial and neck swelling. Using an uncut tube perfectly demonstrates how you have to anticipate this massive, inevitable edema. Think about it. If you cut the tube short, the swelling face and neck might just swallow the end of the tube entirely. That's a nightmare. And keep in mind, because the anatomy gets distorted so fast, you might need a fiber optic intubation if the airway looks difficult. Moving on, I want you to lock this number firmly into your memory: 48 hours. If you need to use a paralytic for intubation or any other procedure, succinylcholine must be avoided after 48 hours in burn patients. Why? Because all that massive tissue damage causes an upregulation of acetylcholine receptors. Giving succinylcholine after that 48-hour window carries a literally life-threatening risk of hyperkalemia. No way you want to risk that.
Let's shift gears to Section 2, Burn Center Referral Criteria. We're talking the mandatory American Burn Association guidelines here, extremely high-yield topic. So, there are very strict TBSA percentage thresholds for a mandatory referral. For adults, a partial or full-thickness burn greater than 20% TBSA means an automatic referral. For kids, that threshold drops to greater than 10%. And for literally any patient, a full-thickness burn of greater than 5% TBSA means they've got to go to a specialized center. This strict cutoff totally explains why a patient with a 25% TBSA burn has to be referred. But actually, note what isn't a factor here. A superficial burn under 5% TBSA is absolutely not a criterion for referral. Beyond just the total surface area, the location and mechanism of the burn dictate referral as well. Any burns involving the face, hands, feet, genitalia, or major joints, they demand specialized care. For example, say you have a patient with a 15% full-thickness burn on their face and hands. Even though that TBSA might seem moderate based on what we just talked about, they require immediate referral to a burn unit. Same goes for electrical burns, chemical burns, inhalation injuries, and any cases complicated by significant trauma, major comorbidities, or special populations, like children, the elderly, or pregnant patients. Now, out of all those categories, let's highlight a major exam pearl. What is the single most important criterion for a burn center referral? The answer is inhalation injury. Never ever forget that inhalation injury carries the absolute highest mortality risk. When you combine that with a large TBSA, you're looking at the worst possible prognosis. It's the single factor that rockets a patient's risk profile up more than anything else. All right, on to Section 3, Phases of Burn Management. Now that we've covered immediate stabilization and referral, let's map out the whole chronological clinical pathway, tracing the patient's journey from emergent injury all the way to recovery. Burn management is pretty cleanly divided into 3 distinct temporal phases. First up is the emergent or resuscitative phase, which spans that critical 0 to 48-hour window. That then transitions into the acute phase, which lasts for days to weeks, and finally the rehabilitation phase, which can go on for months or even years. Let's compare those first two. In the emergent phase, your one and only focus is keeping the patient alive. Airway, ABCs, and aggressive fluid resuscitation. This is exactly where you apply the famous Parkland formula during those first 24 to 48 hours. Now notice how that totally shifts when we move to the acute phase. Once they're stabilized, the focus pivots to early wound excision and grafting, strict infection control, and aggressive nutritional support to help their body actually heal. Then we have the final phase, the rehabilitation phase, which is entirely dedicated to functional and cosmetic recovery. We're primarily looking at long-term scar management and preventing contractures. When we talk about late reconstruction here, we mean the surgical release of contractures that might have already formed, plus various cosmetic procedures. Also, and this is absolutely essential during this long-term phase, ongoing psychological support. Which brings us to Section 4, High-Yield Clinical Pearls. For a final section, we're going to rapid fire through the remaining overarching pearls you absolutely cannot afford to miss. Here's another vital question that really tests your grasp on pathophysiology. Why is hypothermia such a major risk in burn patients? Think about what the primary function of the skin actually is.
Why are patients with large burns so incredibly vulnerable to extreme cold? Right. It's due to the loss of the skin barrier and that massive exposed surface area. The skin is our body's primary thermoregulator. When it's burned away, it's basically a massive mechanical failure of the body's natural insulation. Because of this, aggressive thermal monitoring and active warming are an absolute must for all major burn cases. Let's look at 3 more really pervasive clinical issues that span across every phase of care. First, infection risk. You always give tetanus prophylaxis. It's indicated in all major burns. Second, severe pain. You've got to use multimodal pain management, combining opioids and adjunct therapies simply because burn pain is notoriously severe and it lasts a long time. Third, mental trauma. You have to anticipate severe psychological complications like PTSD. They are incredibly common, especially if the patient suffered facial burns or has a really large TBSA.
Okay, to summarize our explainer today, lock in these 4 final takeaways from our checklist to ensure you've absolutely mastered this topic. 1, airway is always first. Early intubation saves lives, especially with that rapid edema we talked about. 2, memorize those ABA burn center referral criteria. They are strict and they are heavily tested. 3, always remember the workflow: airway, then fluids, then wounds, nutrition, and finally rehab. And 4, inhalation injury plus a large TBSI equals the absolute worst prognosis in the box.
So have you mastered the burn boot camp? You've got the underlying theory and the exam pearls totally locked down now. But the real question is, how will you confidently apply these high-yield principles during your next trauma bay rotation, or when you're staring down those upcoming board exams? Stay focused, keep synthesizing what you learn, and we'll see you in the next explainer.